All right. Hi, everybody. I think it is about 6 p.m. Pacific Standard Time. This is Mike with PhysioU, and excited to spend a little bit of time this evening with you talking about shoulder pain. And so I want to take a moment actually to say hello to everyone. It's been a couple of weeks. We've been busy. We've been getting a lot of apps ready. We're in the final phases of looking at fine-tuning the Gait app. We're actually doing a lot of tweaks to the Gait app to make it more user-friendly. And also, today we spent the whole day filming updates for some of our current apps and other apps that we're about to release. So we have a lot of exciting things to tell you about shortly. But today, first off, I want to say welcome to all the new APU DPT students. Today was the first day of orientation. I saw all of you and was excited to spend time with you. And welcome to the coolest profession, right, on earth. Is there a person on the street that cannot benefit from the movement specialist being able to impact their lives and make a difference? So I think that's what's really exciting and really special about our profession, is that we can impact the lives of everybody around us, right? Isn't that a cool way to earn a living? Isn't that a cool way to contribute to society? So I'm excited to be with you here today. And today, let me paint the picture of the patient that I'm thinking about, okay? So I'm going to turn my teacher face off. I'm having a lot of shoulder pain, and I have no idea. It just kind of started, and if I try to reach, I can't quite reach. It's painful. It's keeping me up late at night. I can barely sleep. No, I didn't really injure it at all, so I don't exactly know how it's happened, but it seems to be getting worse. Okay, and if I try to lift my arm, it's really painful. But I can kind of get it out there, but I can't really get my arm out very far, and I'm kind of having a hard time reaching back, okay? The thing that I want to mention, any thoughts actually? So I know I've titled this talk as a certain talk, but just for those of you who are out there, I want you to just type in for a second. What is this particular pattern very characteristic of? And what about that presentation actually is characteristic of this particular problem? So just take a moment. I'm watching whoever's out there. What about that first presentation of the patient that kind of draws you in and says, ooh, I recognize that pattern. I recognize that clinical pattern. Okay? So what are a few things that I just said to you? Let me add in that I'm a 45-year-old male, okay? And I have a history of diabetes and some thyroid problems, okay? So I'm adding some key features. What are some of the things that I've just said? I have terrible shoulder pain. I have no idea how it happened. I have difficulty reaching, but I can get my arm up there if I try. So I'm just curious, what are the kind of things that you are seeing in that history or in that particular functional movement that the patient's displaying for you? What are some of the things that are triggering your recognition of that pattern? So anybody out there, any thoughts? Go ahead and type it in. What are the characteristic findings of this patient who is presenting to you, who says, I'm having problems moving my arm above head, right? And how is that different? How is that different from any of the other conditions? Okay, so anybody? Any thoughts from anybody? Okay, what are your thoughts? This patient walks in, 45-year-old male, saying he has gradually worsening shoulder pain. So I guess the first question you can ask yourself is that traumatic? Or is it atraumatic? Was there a mechanism of injury, right? One of the things that is very characteristic, any of your thoughts out there, what is characteristic about this first phase of frozen shoulder? So for those of you guys who have just joined us, we looked at a patient pattern, gradually worsening shoulder pain. I have kind of full range of motion, but I'm kind of losing some range of motion, some gradual loss. What are some key things that are very characteristic of this first phase of frozen shoulder? What are your thoughts? Okay, so as you guys are typing in some of your thoughts, what I want to do in these next few minutes is talk about how frozen shoulder is not always frozen, right? And so we cannot, the guidelines are very, very good about breaking up the phases of frozen shoulder, what is characteristic of each phase, and why we need to manage them different, right? I think that is one of the really important skill sets of a therapist, is to recognize the pattern, the overall pattern, say I recognize his signs and symptoms, I can actually differential out why he's not the other shoulder conditions, and determine what is the main thing I should manage for this patient today. Okay, so let me just make a couple of comments as you guys are making your notes. I don't see anybody writing any particular notes yet, but please keep them coming in. Any of your thoughts? What are the key findings of frozen shoulder, the first phase? So that's my key question to you. Any thoughts out there? What would you be looking for to say, ah, yes, I recognize you. You're first phase of frozen shoulder. I know what to do with you. I know how to help you. Okay? Let me just point out a few risk factors, okay? Diabetics, history of diabetes, history of thyroid problems, okay? Age between 40 and 65 years old. Okay, so we're not talking necessarily about the younger group, right? We're looking at the middle-aged and older group. Female more often than male, right? And gradually worsening pain. Commonly, there's no real mechanism of injury. They're just coming to you and saying, my shoulder has started hurting. My motion is getting worse and worse, right? My motion is getting worse and worse. But I still have my motion, it's just getting worse. Is that a picture that makes sense? Well, there's no mechanism of injury. That's when you go, ah, something systemic, more systemic might be going on. And remember, most problems with rest, with sleep, with time, they feel better. Except this problem seems to get worse with time. The disability seems to be increasing with time. When they go to bed, they can't even fall asleep. That is very characteristic of the first phase. Okay? So, the first phase is characterized as sharp, achy pain at the end ranges, right? And it might not be a lot of end ranges, right? It could just be sharp, achy pain at end ranges, and lots of times they have pretty decent range of motion when you go to look, when you assess their passive range. They'll often complain of sleep disturbances, and when you go in and look at the biology, the pathobiology of the shoulder, you'll see that they have a lot of inflammation going on in there, right? So this patient is a pain-limited shoulder. They're highly irritable. And that pain limit is reducing their function, okay? The other key findings for this first phase of frozen shoulder is significant loss of external rotation and progressively decreasing external rotation, but the rotator cuff is intact, right? So that kind of rules out the rotator cuff tear, it rules out the impingement person, and you're gradually getting worse, but your rotator cuff strength is still pretty good. So on your static rotator cuff testing, right? External rotation, abduction, internal rotation, patient's relatively strong. But they're just having this achy pain that's disturbing them at night. Okay, so that's phase one. Any other thoughts? Any other thoughts of what you guys are thinking about in terms of what's the next phase? Okay? So this first phase one, another key component, a good therapist realizes that this problem is not a problem that's going to go away quick. So when the therapist can tell the patient, hey, you know what? I recognize this problem, you're going to be okay, but it's going to take a little while to get better. Don't be afraid, you're in good hands. You have just helped the patient a lot. You've given them a light at the end of the tunnel, okay? So let's talk about stage two. Now, stage two, what do you think stage two is called based on the guidelines? So any of you out there, any thoughts on what phase two of frozen shoulder is called? Okay? Good. It looks like let's see if I can pull up some of these comments here. It looks like you guys are making some good comments. For some reason, I cannot see them. And I see some cool filters. Nope, that's not what I want. Okay. I'm going to say, so I see some of you making good comments. Keep them coming in. Unfortunately, I can't see them for a moment, but stage 2 is essentially the painful or freezing phase. Okay? And in this phase, the motion is gradually getting worse. What do you think is going on in the synovium in the shoulder? The synovium is still heavily inflamed. This is still a very painful stage. So if you think about my priorities as a therapist, right? Your shoulder is very, very painful. It's already inflamed. Is this the time to be mobbing them at end range and stretching them at end range, right? We always have to allow irritability to guide our treatment, patient's irritability. We have to determine what is the key impairment I need to manage now. So here in this stage, which is basically 3 to 9 months, okay, 3 to 9 months, think about that. We're going to have to walk side by side and educate our patients in these phases and help them get the care that they need. And the guidelines actually talks about it's okay to use modalities. It's okay to get them to go to their GP or their primary care doc and get a corticosteroid injection. Guideline says that's okay. Okay? So it's the painful phase. All right, so let's move on. I just want to move through the phases because one of the key parts that I want to talk about is to get your thoughts on how do I manage these patients in these different phases, right? That's the skill of the therapist. How do I manage these problems as they pass through these different phases? How do I do the right thing, right? So, okay, stage 3. Stage 3, now the patient says, that's about as far as I can go. Ugh. Now, the interesting thing is, could a rotator cuff tear look like that? Ugh, can't bring my arm up. It could, right? So the history is very important, right? I started 9 months ago and my pain got really bad, my range of motion got really limited, and now my pain's getting better, but I am stuck. This is the frozen stage. It's 9 to 15 months. It's still quite painful, but when you look at the joint, the synovitis has calmed down. This is not a primary inflammatory condition anymore. So now the patient says, my life sucks not because it's as painful anymore. This is way better than before. I can sleep now. But now, I can't wipe. I can't put on my bra. I can't get my arm up to do my hair. Now, they're shoulder pain with mobility deficits. Okay? Now they're really limited. What do you think you're going to find with active range of motion and passive range of motion? Right? What are the key findings? How do I examine this patient? What should I do in my physical exam? This is a mobility deficit problem in which the primary part of your exam is assessing active and passive range of motion and accessory mobility. That's the main thing. And then we'll talk about ruling in and ruling out in 1 second, okay? So, think about what does it mean now that I'm in the frozen phase, I'm no longer really inflamed, then maybe I can begin to pull away from some of the pain reduction type modalities, pain reducing type treatments, because I need to start getting busy restoring their main impairment, which is now their range of motion impairment. Is that fair? So they have primarily what's going on now in the joint is just fibrosis. The axillary fold is getting stuck. Their range of motion is very limited. Active and passive range is limited. And let me also suggest that if the humerus is not moving, the scapulas may not be moving very much either, unless they're compensating. In order to lift their arm, they're shrugging their shoulder, right? So this is a common pattern that we see. When people are trying to reach, they're trying to gain shoulder elevation using the scapulothoracic joint. All right, okay, so the scapula may be limited in certain directions and it may be moving a lot in certain directions. Think about that. This is the frozen phase. Okay, so we just went through 2 very irritable phases. The frozen phase, which is really from 9 to 15 months. And then we finally get to the thawing phase. The thawing phase, think about this, 15 to 24 months from onset, we are still in the thawing phase, okay? Imagine that as a good therapist, that you are going to be walking side by side with them, helping to restore their function, knowing that they're going to go through these different phases, and you can be their tour guide. You can reduce their fear and can tell them to do the right things at the right phases. That's what a good therapist will do. Now, the pain is getting less. It's the thawing phase. The range of motion is getting a little bit better, but there's still stiffness. The evidence seems to suggest that people, though their pain gets better, lots of times they don't get their full range of motion back. That's where we come in, right? That's where the movement specialist says, when it's time, I'm going to get in there and help restore your range of motion because that's what I do. That's in my realm of what I take care of as a movement specialist, right? So that's what I think a really critical part is. When the time is right, we go full force into taking care of the key impairments. All right, so a few other thoughts, okay? So I'm looking out for comments here. Yep, I see you guys making some good comments. Okay, how do I rule in that this is frozen shoulder? Let me just do a snapshot of the key things that the guideline says, and I would highly recommend you go to JOSPT or orthopt.org and look up the guidelines. This is the first set of guidelines that really teased out these different conditions and tried to stratify the evaluation and the treatment based on irritability. Is really quite ingenious. Really kudos to the guideline writers, right? And we had a ton of fun when we were building the shoulder app, trying to bring out the nuances that these guideline writers did such a good job on trying to tease out. Frozen shoulder is not always frozen. It goes through different phases, okay? So ruling in, take note of these key things. When you're ruling in frozen shoulder, they're generally older, 40 to 65 years old. Females often have it more than males. They may have a history of thyroid disease or diabetes, and a previous history of contralateral frozen shoulder. So I'm having frozen shoulder here. I've had it before here. So my system is predisposed to this type of ankylosing problem, okay? So keep that in mind. A couple of other things. Range of motion loss, right? A lot of these range of motion losses, think about the key patterns in the guidelines. The guidelines, when you look at the algorithm in the guidelines, they say some people have shoulder pain. It's because they're stuck, mobility deficits. Another group, what do you think the other group? What's the other common group of people with shoulder pain? A lot of them have shoulder pain because they fell, they went too far, they repetitively throw, they're having movement coordination impairments, they're unstable, they have labral tears, slap lesions, their joint moves too much. This is move too much. This other case, mobility deficits, move too little, right? Totally different end of the spectrum. And then the third category in the algorithm, and I'd invite you to look at the algorithm in the guidelines, is this category is, I hurt on the way up. I have a pinch in my shoulder. I don't have a range of motion loss. I have a power deficit. I have problems getting my arm up. That's the rotator cuff tear impingement group. 3 main shoulder categories, right? You don't have to make shoulder pain so complicated. I would say the guideline says 3 big categories. Okay, if you can take care of these 3 big ones and recognize how to treat them, and we'll talk about each of these categories, you've helped a lot of people with shoulder problems. Okay, so, all right, moving on. So ruling in, loss of range of motion, global loss of range of motion, but if you think about this, external rotation, range of motion, if this is a capsular problem, as I go from 45 degrees of abduction to 90 degrees of abduction, what should happen to my external rotation if this is a capsular problem? Essentially, I should get less range of motion because I'm putting my shoulder in a closed pack position, right? Okay, so I'm winding up the capsule. If I have capsular restrictions, it should get harder and harder to get external rotation. This is characteristic of frozen shoulder. A few other couple things. Loss of active and passive range of motion and accessory motion loss, because that's how we assess people with mobility deficits. We'll talk about this over and over again. When you look at mobility deficits, you are looking at losses of active and passive range of motion and accessory mobility. Okay, moving on. So we've got some accessory glide loss, some range of motion loss, and how do I rule it out? What are characteristic of the other patterns that help me tell that this may not be frozen shoulder? Okay, so I'm going to just lay it out there. If the patient has passive range of motion and it's normal, it's not frozen. Okay, so that's key, right? You can't be a mobility deficit and have full range of motion. So if they have good range of motion, it's not frozen shoulder. If they have radiographic evidence of glenohumeral joint arthritis, the guidelines also says may not be frozen shoulder, it might just be arthritis. Okay? Passive external rotation. Remember I said external rotation, if it's a frozen shoulder, as I take my arm up into abduction, my external rotation should get less and less, right? Because my capsule is getting tighter. In some cases, if you're at 45 degrees, you have a certain amount of external rotation, but as you go up higher, your external rotation improves, along with palpation of the subscap, okay, the subscapularis. That particular pattern, so range of motion of external rotation improves as you wind up the shoulder capsule. That's actually the subscap, potentially, and your palpation of the subscap, you might need to just treat the subscap, right? Soft tissue mobilization, contract, relax, and then some type of PNF to improve the range of motion, okay? So, the guideline says that's one of the patterns you need to watch out for. And then lastly, if the patient's complaining of tons of burning pain, aching pain, inevitably, you should be clearing the cervical spine, right? And we can clear it with a few quick provocative maneuvers, probably a Sperling's or some type of decompression, right? Distraction, see if the shoulder pain gets better. But you need to do a neurodynamic, upper limb neurodynamic test. And the question is, can I do that when the patient can't even raise their arm? Absolutely, you can do your upper limb neurodynamic test for median nerve with the arm by side. Okay, so you do the lower angle one. Okay, and test. Can you change the shoulder pain with wrist movements? If it's a neurodynamic problem, then treat it as a neurodynamic problem. Okay, so those are the main things, and the guidelines also says, well, palpate the different nerve trunks. See if you can reproduce pain on the nerve trunks to see if it's really a nerve problem, not a frozen shoulder problem. Okay, so what we just did is talked about the phases, talked about some key rule in and rule out things that the guidelines talks about. So in this last 5 minutes, I want to just throw out a few key thoughts, okay? What am I going to do about the highly irritable patient? Okay, so the guideline says if they have greater than 7 out of 10, they have very high disability, they have night pain, they can't fall asleep, right? So they're fatigued, they have a lot of night pain, whereas, think about this, shoulder impingement, shoulder instability, most of those problems, a sprain or strain of the shoulder, they feel better when you've rested at night. But this problem, high irritability, right, the freezing phase, these patients are complaining of more and more pain, and it's getting worse, and it keeps them up at night. That's inconsistent with a typical mechanical problem, but it's very consistent with an inflammatory problem, right? Okay, so high levels of disability. Pain occurs before end range, right? I can get up here, but I have so much pain. That's the inflammation speaking to you, right? So that active range of motion is significantly less than passive range of motion. This person is pain limited. What are the kind of things that I would do to help this person? Let me just suggest that in this phase, we do a lot of gentle movements that are pain-free. Lots of gentle movements that are pain-free, and a lot of encouragement, modalities that will reduce their symptoms. Work hand in hand with primary care to see if they have pain-relieving medications, and relieve the patient's fears, right? Tell them, hey, I recognize this problem, you're going to be okay. It's going to take a little while, but these are the things that we're going to do to help you along the way. This phase, the highly irritable phase, is not the phase that you're going to do a lot of forceful movements and end range movements. They are pain limited. They're inflamed. You take care of pain, you help them find comfortable positions, and have confidence that that's the right thing to do. And let them move gently in pain-free ranges. Okay, that's it. Pendulums, right? All your basic stuff. This is not end range time. Okay? Moderate irritability. This is the pain levels are about 4 to 6 out of 10, right? So slightly lower in the moderate range. They may have intermittent night pain. So their night pain's getting a little better. They're telling you, hey, I'm sleeping a little bit better. And basically my disability is improving. I now have more pain at the end ranges, but my active range and passive range are the same or very similar because I'm frozen. It's a capsular pattern. Active and passive range, typically even, equally limited, and external rotation, very limited. Hand behind back, which is very characteristic of frozen shoulder, very limited. And my accessory mobility is limited. In this phase, you can still, they're still painful, remember, so we can still use some modalities. We can still use some type of gentle modalities, but we're now going to slowly, progressively apply more moderate forces to your mobilizations, more moderate stretches, but we're not heading heavily into the end range until their irritability continues to go down, right? So we're actually walking with them. Highly irritable, I'll take care of your pain and keep your movements pain-free. Now I'm moderately irritable, I'm going to slowly wean you off the pain stuff. I'm slowly going to push you a little bit, but remember that this is still often an inflammatory condition. Do not push them so hard that you're going to create more inflammation, more fibrosis, and now you're just working against yourself. The patient is more painful, losing range of motion, right? This is one of the key measures of how hard should I push. Okay, so in this moderate phase, the skillful therapist is pushing, but not pushing so hard to create a post-treatment inflammation. Okay, and finally, I know we're running out of time here. Finally, in this last couple of minutes, we are now in the thawing phase. The pain is reduced. It's primarily fibrosis that we're working on. So, hey, take them to end range. Mobilize them with a little bit more vigor. Hang out at end range more end range stretches. At this point, the patient should know, hey, a little bit of discomfort at the end ranges is how we're going to get you to your goal. Okay? So think about that. We have just talked about frozen shoulder that isn't always frozen. It goes through different phases. There's different time frames that I can recognize. And based on the patient's irritability, I'm going to target different things so that I don't make them worse, pushing too hard too early, or become completely ineffective and not push hard enough when they need me to help them gain their end range. In the moderate and low irritability phases of treatment, the guideline says, you know what, once you restore some range of motion, help them do their PNF patterns. Help them use their new range of motion to help them transition back into function. Okay? So, hey, guys, thank you so much for hanging out with me. Thank you to all the professors who have been writing in to help us continue to refine the app. It's very fascinating how the different schools on the East Coast and the West Coast, the different textbooks that we use, how different sometimes range of motion, MMT, how different those can be. But again, we are taking all of that into account to build you the best resources for learning. We have a lot of exciting things coming out. Keep track of us on Facebook. And thank you guys for being a part of this awesome profession. Look forward to seeing you guys probably next week, and also seeing you guys at CSM. We have a lot of great talks prepared for you, and also we'll be launching a bunch of cool apps. So anyways, you guys have a great evening. Thanks for being a part of Name That Pattern Live. We just finished talking about frozen shoulder, and we'll do another session next week. Looking forward to seeing you guys. Take care and have a good evening.